about given the title of challenging whole labs. This is my passion, and it is also a dream surgery because I'm dreaming about it now because I've stopped doing it since January. So this is the outline of my talk. Why do we do whole lab? My usual setup, equipment, and technique. Patient positioning and some challenges, and the usual challenges that we have: anticoagulated patients, very big prostates, elderly patients, whole lab in prostate cancer, troubleshooting the equipment and application side while doing whole lab. So I think it's a very nice article showing the trends of BPH surgery in Korea. TURP has maintained stable over the years, and you can see whole lab has taken on in a big way in South Korea. And why we do whole lab? I think this is a very elegant study from France, 2.6 million population for BPH, and you can see the number of surgeries they did in 2004 to 2008, more than 64,000. And you can see the gold standard that we are up against, which is TURP. It's about a 5 to 10% reoperation rate as we follow up the patient. And again, this is a patient that I recently saw, 71 years old. He had 64 grams TURP done in 2011, and now represented with gross hematuria. Flex scope shows still a prostatic enlargement with some dystrophic calcification, and a CT scan was done, which shows that the remnant. So it's awaiting another surgical procedure once we are out of our lockdown. This article from European Urology tells us the pros and cons of each procedure. Definitely whole lab, there's the technical, the learning curve that is always mentioned in literature, as well as the incontinence in the early post-operative period, which can bother patients compared with other modalities of treatment for BPH. And we have a series which tells us all the complications encountered during whole lab. This is a big series from Barcelona, Spain. And just looking at the perioperative complications in the first month, you can see most of them are fairly, there's no TUR syndrome, UTI recatheterization rates, and hematuria requiring readmission of bladder irrigations is not that high. For the medium-term complications, there are some small 1% reoperation for bladder neck contracture. I think the main complication that we have to warn patients about during whole lab is the stress urinary incontinence. In this series, about 5%. I usually quote about 10% up to 3 months. And I think I just have one patient that had about 6 months of incontinence requiring pads. And so this is a paper from JEuro, 300 patients from Egypt, 3 surgeons in 2012. And I think the main is that they looked at their learning curve, and urinary incontinence is the most relevant clinical outcome. And so I think once you get through the learning curve, it's actually quite a satisfying procedure. So this is the setup that I have in my clinic. We're allowed to do bedside ultrasound. I have the Flex Focus 500 BK medical, which we use for trus biopsies as well. I try to estimate the prostate size by myself in patient, including their comorbids. Using the ellipse, I use, with this picture here, you can see a volume of 52. Usually it correlates quite well with the amount of histology I can get. So in this patient, I think I managed to do a whole lab of 48 grams for him. And this is our OT setup. This is the setup that we have. This is when surgery is ongoing. The laser machine, the high power laser machine with the irrigation stack. This is the setting that laser setting that I use. I actually don't use 90 watts when I enucleate. I just tend to use 48 watts, and it's usually more than sufficient for enucleation. And there's more and more in the literature saying low power, people doing low power enucleation. And instead of the usual Timberlake obturator, I tend to use a visual obturator, which allows me to go in under direct vision and makes the introduction of the resectoscope sheath safer. So I think, as with whole lab, there is always a natural plane which exists in the state. I think the most important bit is to have a systematic way of enucleating so that we do not get lost, especially in bigger prostates and more challenging prostates. There are many ways to create a prostate, 2 lobes, 3 lobes. I tend to do a 2-lobe technique, and these are my enucleation steps. I separate the mucosa from 4 o'clock along the roof that we do a BNI. And I think the plane is easiest found at the apex. So the second step on the right, I usually develop the apex until it's totally free at about 1 to 3 o'clock. And then once the apex is fully free, I develop the lateral and enter the bladder at about 1 to 3 o'clock. That's the safest place to enter. There's no dangerous structures there. And then I do the anterior commissure. And then the bottom, always do the bottom bit last so that there's no undermining of the bladder neck. So I'm just showing you, hopefully the video runs. This is just doing the apical blit using 48 watts. And there's always a naturally occurring plane. Usually, I like this Olympus resectoscope, which has the metal loops, sort of like a finger to find the resection plane. And you can see those fibers which part, that's the natural occurring plane in the capsule. As you can see it splitting. I just apply a gentle laser energy to split it apart. I think over here there's a slight bleeder, just defocus a bit, and then we carry on. So usually once the apex is free, the prostate starts to rock, and when the prostate starts to rock, you are able to find the plane quite easily. And this is the slightly, I think I tend to have the most difficult bring the mucosa completing. So this is the anterior commissure. So that I've already entered the bladder at about 1 to 3 o'clock on the lateral aspect. So I'm doing the anterior commissure now. This part I managed to capture the separation of the mucosa quite elegantly. Sometimes when we are operating upside down, the resectoscope sheath irrigation is not too good. So sometimes the videos are, right. So this is the verum montandum, just flipping up now. So I usually develop to separate the mucosa. So once you separate from the mucosa, there's less tugging on the sphincter. And then you have less transient stress incontinence. So here it's near the bladder neck, so I just go horizontally across. And again, I think the trick is not to have too many cross planes, and then you get confused which part of the prostate you are enucleating. Just going to reach the crucial bit in a while. So so that I'm joining up to where I entered the bladder at about 2 o'clock. And now this is the last remnant mucosa bridge that's holding. So that is the sphincteric arch, that's the sphincter. And this is the last mucosa bridge that's holding the prostate. So I just go horizontally across. And once this mucosa is free, the prostate is no longer tugging on the sphincter. And that decreases the stress incontinence that happens when we use too much a blunt dissection during enucleation. As you can see, I just go horizontally across and you encounter the white fibrils, and I then climb the prostate and then re-up. So I make sure the entire top of the prostate is free, and then I only have the inferior attachment, then I develop that and the whole lobe falls into the bladder. So moving again, the laser is a very hemostatic equipment. It's an elegant study done by the Koreans. As you can see, the apex, there's not much bleeders. You encounter and you tend to encounter the bleeders at the middle and the proximal and distal prostate. As you can see, those numbers reflect the bleeders that you can estimate. So I think most people enucleate starting from the apex, so it's easy. So coming to the positioning of patients, this is a patient that I operated on. He's in a mobility device because he had above knee amputation due to peripheral vascular disease and was on a catheter for a few months. So again, the positioning is a bit slightly tricky when the patient has a BKA or an AKA, but it can be done. Going on to more challenging patients, I think HoLEP, yes, it can be done for anticoagulate patients, but they tend to have significant comorbidities. I did this 69-year-old man. As you can see, he has DVT, AF, ischemic heart disease, and just had a drug-eluting stent done February last year. Had to convince quite a few anesthetists to allow me to proceed for the procedure. During the surgery, it's a big prostate. Estimated volume was 130. During the procedure, he developed some small atopics, and I was in communication with the anesthetist. We decided one lobe is good enough. So we did Hemi HoLEP. Histo was 68 grams. And he had one more episode of a secondary bleed 2 weeks later, resolved with bladder irrigation. That was his flow rate post-op. His post-op PSA is 4.7. He declined another HoLEP, and anyway, now we are in lockdown mode. So otherwise, he did fairly well. So again, that's you do one lobe, the patient is unstable. You can always back out, and they usually do quite all right. And we come down to what we do HoLEPs for the very big prostates. This is 79-year-old. Based on the CD scan, the estimated prostate volume was about 200 plus. Only comorbid of hypertension, and PSA was 4.4. So he had almost 300 stones. It took about 45 minutes to evacuate all these tiny stones. Again, the anesthetist said he was quite stable, so I proceeded on to complete his HoLEP, and this is his post-operative flow. So again, big prostates, we have to be wary of longer operative times. Again, I'll show you my complications later. And then we are faced with a cohort of elderly patients, very elderly patients. This is an example of a 93-year-old with background hypertension. He's on a catheter for about 6 years. I saw me in clinic. He's got fairly good ECOG, still doing all his activities of daily living. So went ahead and did a HoLEP for him successfully. Just a bit of data from my own series. I've done 16 patients above 80 years old. The mean age was 84. The oldest is 94. Again, most of them are chronic retention. And preoperative IDC duration has been up to 6 years. Some of them wearing it for 1 to 2 years. Most of the time is convincing the patient's relatives and the patient to undertake surgery, because most of them are elderly and gotten used to wearing a catheter. The enucleation time is about an hour. The histo weight is about 54 grams. with an inequalency of 0.89 grams. The length of stay is a bit on the longer side, 5 days, because most of them have been on long-term catheters requiring some form of antibiotics. And the mean IDC after operation was about 59 hours. 2 patients turned out to have cancer. Good people, all of them had successful trial of catheters. From the Clavin-Dindo complications, one required blood transfusion and one required IV antibiotics, and one had a grade 3 complication needing cystodermy. I think that was quite a bad decompression hematuria after morcellation. So again, we can do whole labs for prostate cancer, especially in the elderly. Sometimes we just encounter cancer. I find that if the PSA is less than 30, usually there is a good plane for irrigation, but when a PSA goes above 50, the percentage of cancer is significant, and sometimes doing a whole lab rather than a whole lab because there's no more planes and the cancer has invaded through the planes. He developed bladder neck contracture after the whole lab, but at least we got him off the catheter. So again, I think that here is where I think whole lab has a role for innovation and technology. Just showing whole lab, the morcellation bit. So this is the Stotz morcellator which I use, and usually we use 3000 RPM. If you use any faster, sometimes it's just like stone surgery. The prostate adenoma just ricochets off the morcellator when it's moving too fast. And in good morcellation, you can see, you must be able to see the good morcellation. And sometimes with this Stotz morcellator, the nurse is helping me unclog it. So unfortunately, a lot of these is troubleshooting your equipment to know so that your morcellation runs off, goes smoothly. This is the this is the Olympus nephroscope, so that I can interchange back to do more hemostasis if it's necessary. This Olympus nephroscope is designed for morcellation, so that's interchangeable with the laser resectoscope. So this is one of the cases why I accidentally either the irrigation stopped and you can see it's almost like quite a radical QRBD done by the morcellator. Again, quite scary when the morcellation doesn't go well. Usually this would usually it's not a full through and through perforation, but even then, it's quite frustrating when we have complications during morcellation. So again, as with anything, people are doing green light vaporization. I took this diagram off just to illustrate. There's a capsule, and we should try not to perforate the capsule. And again, the prosthetic capsule is quite deficient, especially near the bladder neck. So we should be cognizant when we have actually deep perforation. This is one of my patients. Did the whole lab. I saw fat near the bladder neck, and he developed abdominal tenderness after the surgery. And he was quite tense, and as you can see, there can be quite significant extravasation of fluid through the retroperitoneal space, even into the intraperitoneal space due to a prosthetic capsule. So yeah. And this was a complication whereby similar case whereby there was significant extravasation due to morcellation issues, and the fluid extravasate, and I wasn't able to distend the bladder during morcellation and felt it was not safe. So I did an open cystostomy and the edema. So again, another complication from morcellation and fluid extravasation. Again, it's in the literature. Whole lab, as with any mutation, when we reach the capsule, it can extravasate and cause even abdominal compartment syndrome. So I think, this is a very article for anyone interested in andrology. In the younger patient, less than 60 years old, although this is not the p-value was not significant, but I think if there's no median lobe, in the younger patients less than 60 years old, I tried to leave an ejaculatory hood near the verumontanum. And in this Korean study with HOLAP, they actually managed to preserve antegrade ejaculation for 46% of their patients by leaving this hood for in front of verumontanum. So the take-home messages for HOLAP. I think a correct balance of blunt dissection and laser energy during enucleation. The more blunt dissection you use, probably you get more transient incontinence if you stretch on the sphincter. Follow the plane. Try to avoid capsular perforation. The early mucosa separation also prevents incontinence. Try challenging cases during the learning curve. Know the morcellation equipment well. I think there is a role for innovation and design of morcellator and nephroscope in HOLAPs in the future to make this procedure easy. I've come to the end of my talk. Not done a HOLAP since January. That's Dr. Vinit trying out PAPR. That's me doing fever 10, going to the dormitories, and that's me operating suited up. Thank you. Stay safe, everyone.